And with that, we have mantle cell lymphoma management in North Carolina updates for 2020 with Christopher Dittus, DO, MPH. Dr. Dittus, welcome. Glad to have you on board.
Thank you.
So let's see, Dr. Dittus, you specialize in the diagnosis and management of all types of lymphoma, including B-cell, non-Hodgkin lymphoma, T-cell NHL, and Hodgkin lymphoma. Particularly interested in viral and rare lymphomas, including adult T-cell leukemia lymphoma, extranodal NK T-cell lymphoma, plasmablastic lymphoma, primary central nervous system lymphoma, and Waldenstrom's. Dr. Dittus is also a clinical researcher and specializes in investigator-initiated clinical trials aimed at rare and underserved lymphomas. He serves as the AIDS Malignancy Consortium site PI at UNC. And Dr. Dittus, in addition to all of that, what's one other thing, maybe something a little more personal you can tell us about yourself?
Originally from New York, moved down here about 4.5 years ago with my family, with my wife and my daughter and my son, and we just got a dog named Charlie. He's about eight months old now.
Great. Well, congratulations on that. I mentioned the poll everywhere question, and this is kind of a softball, this first one. So mantle cell lymphoma is a cancer that involves the white blood cells, which are part of the body's immune system. So is that A, true, or B, false? And in just a moment, you'll be able to go ahead and fill that out at our one of the poll everywhere mechanisms I mentioned. While we are, before we do that, just want to mention our disclosures. This activity has been planned and implemented under the sole supervision of course directors in association with the UNC Office of Continuing Professional Development. William Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Christopher Dittus, DO, MPH, has no financial relationships with commercial interests as defined by the ACCME. And with that, we'll go ahead and bring up this poll. And we'll wait just about 10 seconds. I see many of you have already responded to that. So go ahead, and again, this is anonymous, as are all of the questions, so take your best guess. Dr. Dittus, how are they doing?
They're doing very well.
Great.
Yeah. So, and we'll go into this a little more soon.
Oh, okay, terrific. Okay, and without further ado, mantle cell lymphoma management in North Carolina, updates for 2020. I'll turn it over to you.
Thank you. Thanks for having me. Like I said, I'm part of the lymphoma program here at UNC in Chapel Hill. I was initially tasked with giving a talk on lymphoma updates, and I realized that was going to be just probably take days to get through all of that, since lymphoma really is made up of many different individual diseases. So I decided to focus on a disease that can be relatively tricky to treat and can present very differently in different situations, which is mantle cell lymphoma. And I wanted to talk about standard management, workup, as well as some new research findings. We could go to the next slide. So we'll begin with a case presentation, then we'll go into some background information, and then review how to diagnose mantle cell lymphoma, any initial workup, and then at the end we'll spend more time on treatment. So first is the case presentation. So a patient of mine came in several years ago. She's an 82-year-old female. She had no past medical history. She presented with lymph nodes that you could feel, as well as worsening fatigue. She was a very active 82-year-old lady who exercised and was just, going about her life. I put ECOG 0. That means she has a very good performance status. She had on exam palpable lymphadenopathy under her armpits, in her axilla, as well as in her inguinal or groin region. And ultimately, she had a biopsy, an excisional inguinal lymph node biopsy, which was consistent with mantle cell lymphoma. Importantly, it was not a blastoid type of mantle cell lymphoma, which we'll get into. And another important piece of information was that the Ki-67 proliferation index, which is basically a marker of how quickly and how aggressively the cancer, specifically type of lymphoma, is proliferating, was relatively low at 10%. She did have translocation 1114, which is diagnostic of mantle cell lymphoma, and we'll get a little bit more into that moving forward. Her lab work was relatively normal. Her blood counts were all within the normal range. All of her electrolytes, kidney function, liver function was all normal. Her LDH, which is a marker of cellular breakdown and proliferation, was mildly elevated at 763, which we can see in lymphomas. And if it is elevated, it is a marker of lymphoma, and we expect it to come down with treatment. She was negative for viral screenings, including HIV and hepatitis B. This was her staging PET scan. This is the same scan. I don't know if people have looked at PET scans before, but basically you can look at it one of two ways. On the left side, we have the colored version where the brighter yellow or almost white that pops up is lymphoma. Now, some areas, including this kind of sideways U, that's the heart. The bladder down at the bottom can light up. So those are physiologic, meaning normal, but the other areas, particularly around the underarms, as well as all of this yellow in her belly in the middle here, that's all lymphadenopathy. And over on the right is the same scan, but looking at it with in black and white. And over here you could see her arms are actually up over her head, and you can see in her armpits, you see those are all lymph nodes that are involved with her lymphoma. And then if you make your way down to her belly, you basically see this inverted Y shape, and those are all lymph nodes running along her iliac blood vessels, and then down into her groin, which are the inguinal ones. So that was her scan, what it looked like, and we'll be able to see later on what her scan looked like once she was treated. So we can move on. So continuing the case, we started her with surveillance because she was actually, besides feeling, mildly fatigued, she was still able to go about her life, and she wasn't eager to jump into any type of treatment at that point. So we decided to watch her and just have her follow up regularly for surveillance. Ultimately, as we did expect, her lymph nodes did progress and she had worsening fatigue. So we decided to work her up at that time and start treatment. And here we're going to pause from the case, and we'll come back to it later, and we're going to just go into some background information on mantle cell lymphoma. Even broader than that, what is lymphoma? Well, we did touch on this a little bit earlier. Lymphoma is a cancer of mature B cells and T cells. Now, B cells and T cells are a type of, they're both lymphocytes, which are a type of white blood cell. So that's kind of coming back to that initial question. This is a cancer of white blood cells, specifically lymphocytes. Mantle cell is a B cell lymphoma. These are, under normal situations, these are part of your adaptive immune system. B cells are responsible for humoral immunity, and T cells are responsible for something called cell-mediated immunity. So they're just normal cells that are operating in your body to help fight off bacterial, viral, fungal infections all the time. And generally, lymphoma exists in lymph nodes, but as you can imagine, you have immune tissue everywhere in your body. So really, you can get lymphoma anywhere where there is where there is lymphatic tissue, which is literally anywhere in your body. But for the most part, classically, you'll see these diseases in the lymph nodes. And we can move on. I put together a really general breakdown of this is kind of how I describe to a new patient coming in how to think about lymphoma. When you talk about lymphoma, you're talking really about at least 70 or 80 different diseases. And we like to classify them. And, in my mind, when I visualize this, I like to think of it in a branching pattern. And that's why we have this tree here. And really, the first division is Hodgkin versus non-Hodgkin lymphoma. Hodgkin is really its own entity. It is technically a B-cell lymphoma, but it's treated, in its own group. So that really the first big distinction to make is Hodgkin versus non-Hodgkin. So then once we're in the world of non-Hodgkin lymphoma, that's really where you have many, many, many different types. And the first distinction we like to make is this a B-cell or a T-cell non-Hodgkin lymphoma? Now remember, as I mentioned earlier, lymphomas can be B or T cell based on the natural immune cells that you have in your body. The vast majority, about 85%, are B cell lymphomas, including mantle cell. When we talk about B cell lymphomas specifically then, we like to break them down by how they behave clinically. And what I mean by that is, do they grow quickly and cause a lot of illness very, very fast, sometimes on the order of days? Or do they grow slowly? Sometimes you can watch them for years without actually having to start any treatment. And that's one of the interesting things about lymphoma, is that there's a huge variation in how these diseases present and how we need to either initiate treatment or just initiate surveillance. Interestingly, mantle cell is one of the few lymphomas that doesn't fall really neatly into a category. We generally will consider mantle cell to be an aggressive lymphoma. Very rarely, well, not very rarely, but infrequently, we have a leukemic mantle cell variant, which I'll discuss briefly, but this really behaves a lot more indolently, meaning slowly progressing, and we really often don't need to initiate treatment right away, and sometimes they can be washed for years, but that's the minority of mantle cell lymphoma patients. So for the most part, we consider it an aggressive type of lymphoma. We could go on to the next slide. Lymphoma epidemiology, so backtracking a little bit to a more general, talking about just non-Hodgkin lymphoma, so mantle cell falls into that group, but there are many, many other types of non-Hodgkin lymphoma. That accounts for about 75,000 new cases a year in the United States and about 20,000 deaths. This is, if you look at the kind of ranking, it's about 7th overall. If you were to add Hodgkin to that, and then if you were to add some other types of lymphomas that are sometimes classified with leukemias, it probably would bump it up a couple slots. So we're talking about a relatively common type of cancer for overall when you're just talking about lymphoma. But like I said, the important thing is that lymphomas are made up of many, many different types, and really they're treated differently. So what you're at the end of the day dealing with is often a rare disease, and mantle cell fits into the category of a rare disease. So we can move forward to the next slide. This is some SEER data. If you're not familiar, these are basically population level data looking at survival, looking at mortality and incidence, or the number of new cases over time. These are trends from 1975 to 2016. And the top curve are the number of new cases. And you can see it's been readily increasing and then kind of plateaued towards the top. And if you look at the bottom number or line curve, we can see that that there is an increase in deaths up to a point, and then they start coming down. And what happened here in 1995, remember this is all non-Hodgkin lymphoma, the majority of which are B-cell lymphoma. Interestingly, around this time, 96, 97, is when a monoclonal antibody called rituximab was approved, and it really impacted the survival of patients with lymphoma. And we could go. So now, getting more granular, and it's getting more specific on mantle cell lymphoma specifically now, which again is a subtype of non-Hodgkin lymphoma. Like I said, these are usually aggressive, but not considered curable, okay? That is different than other types of aggressive lymphoma, which we are always trying to cure. In this case, we are trying to get patients into very deep remissions that last sometimes a decade or more, but at the end of the day, we are always worried that it could come back. It is a rare disease. Mantle cell makes up only 3 to 6% of non-Hodgkin lymphoma. The incidence is about 0.8 cases per 100,000 people, and there's around 3,000 cases a year in the United States. It favors men, so men are more likely to get mantle cell by an order of 3 to 1, and it is a disease like other non-Hodgkin lymphoma of patients as they get older. People as they get older are at higher risk. Most patients are in their 60s and 70s with this disease. And on the right, we see the breakdown of new cases of different types of lymphoma by age. And you can see the vast majority are taken up by diffuse large B cell, which is this line up at the top. And mantle cell, you have to come all the way down here to see, to find mantle cell. So definitely not one of the more common types of B cell lymphoma. So now moving forward with the diagnosis and workup of mantle cell lymphoma. So as with all types of cancer and very much in lymphoma, getting an adequate excisional lymph node biopsy is very, very important. And the first step after that is to prepare slides and look at them under the microscope, which is what we're seeing over here on the right. For the most part, the cells are small to medium sized and can have a regular nucleus on examination. And the way that we diagnose lymphomas are we use something called immunohistochemical stains and or flow cytometry. These are ways at looking at surface markers on the cells, on the lymphoma cells. And if they express certain markers and not others, we can diagnose one type of lymphoma versus another type. Mantle cell being a B cell lymphoma expresses what we call B cell markers, which won't be found in, say, T cell lymphomas. These are CD19, CD20, PAX5, so these we would expect them to be positive. Mantle cell lymphoma, along with CLL, which is another type of leukemia lymphoma, expresses something called CD5, which is generally a T cell marker, but it's aberrantly expressed in these diseases. And then there's some other markers that we use to further classify mantle cell. The CD23 can help us differentiate between CLL and mantle cell. It's negative in mantle cell and positive in CLL. And then ultimately, though, all of this gives us an idea of what we're dealing with. But in order to clinch the diagnosis, we want to see cyclin D1 expression, which is a protein that's overexpressed, and we can test for that with immunohistochemical stains. And we look for a chromosomal abnormality, a translocation 1114, which is really diagnostic to confirm mantle cell lymphoma. Now, B cells, when they are in a lymph node and maturing, they are something called pre-germinal center, and then germinal center and post-germinal center. And what that means is the germinal center is in the lymph node, and as these B cells go through and grow, they basically get honed to do their job and target, develop antibodies and target pathogens in the body. Most types of lymphoma either arise out of germinal center B cells or post-germinal center B cells. If the B cells have gone on to fully differentiate, they wind up back in the bone marrow, and if you get cancer at that point, it's a different disease called multiple myeloma. Mantle cell as well as CLL are generally considered pre-germinal center, so the cells have not yet gone through the germinal center. And we could go to the next slide. Mantle cell lymphoma development and progression. I'm just walking you through this slide. If you start over on the left, you have a naive B cell. So it's a B cell that has not yet picked up markers and to target cells or bacterial or pathogens in the body. And as it goes through the germinal center and the mantle zone of the lymph node, it slowly will pick up different markers and allow it to target different pathogens in the body. The vast majority of mantle cell lymphomas go through the mantle zone, and then they ultimately will reside in the lymph nodes or any other extranodal tissue. They can then further have more genetic mutations, specifically in TP53, that causes them to become even more aggressive and turn into a blastoid or pleomorphic mantle cell lymphoma, which are very hard to treat. And they are actually, it's a very important prognostically if we know whether the mantle cell are any of these types. And we'll talk about that a little more. But the vast majority are classical mantle cell, and they're right in the middle here on the middle upper portion. Now, remember earlier when I was saying that there is a small population of mantle cell lymphoma patients that have a indolent course that we don't need to treat right away. Those will go through the germinal center and have some different immunohistochemical stains and markers on them, but ultimately will reside more in the bone marrow, spleen, and peripheral blood rather than the lymph nodes. And you may see this manifested as an elevated white blood cell count, and the patient feels fine, and they don't have any lymphadenopathy, and these patients can often just hang out like that for years sometimes, and we don't need to initiate treatment. Eventually, they may need to be treated, but they are a subgroup that we don't always need to treat right away. And we could go on. So what are these high-risk features? So what are the features that make me more concerned if a mantle cell lymphoma patient is coming into my office and I want to know, is this someone who is going to have a high likelihood of getting in remission, staying in remission for many, many years, or am I going to be dealing with a case where I'm going to treat the patient and they're going to relapse very quickly? And really, there's four things that are important. Probably the most important is to know morphologically, is it a blastoid variant? And you can tell this by looking at the cells under the microscope. The cells are bigger and the nucleus is larger in these cells. There is an increased risk of CNS, meaning central nervous system relapse, meaning these patients can have their mantle cell a relapse in their brain or spinal fluid. And that's important clinically to know that. The Ki-67, which is a proliferation index, which we touched on earlier, is important. Remember, our patient that we talked about earlier was 10%. In mantle cell, if it's over 30%, that's a higher risk factor for CNS relapse. Molecular testing, we can test for TP53 if that's mutated. That's a higher, and that does correlate somewhat with the blastoid type, and those are going to be higher risk patients. And then we have a prognostic score. For lymphomas, classically we have the MIPI or IPI score, which we use for diffuse large B-cell lymphoma, which is the most common type of lymphoma. And then many other different types of lymphoma have a variation of that prognostic score. In mantle cell, it's the MIPI, which is the mantle cell IPI, and we'll go over that quickly in a few minutes. So we could go to the next slide. This is a chart. This is a study that's from 2001. I included it because it's really one of the earlier studies showing the importance of the Blastic or blastoid variant. And you could see they looked back at patients who had the common type of mantle cell versus the Blastic variant, and they showed that patients did much worse if they had the Blastic variant with the median survival of about a year versus a median survival of almost 5 years if they were not the blastoid variant. So that was, there's been other studies since then, but this was really one of the early landmark studies showing that. So we know that the Blastic or blastoid variant does increase your risk of progression and poor survival. Next. Thanks, Tim. Ki-67 over 30%. Remember, I mentioned that it is associated with an increased risk of CNS, meaning central nervous system, aka brain or spinal fluid relapse. And this was a study from a few years ago showing patients who had a Ki-67 over 30 versus less than 30, and this was a significant difference. The cumulative incidence of CNS relapse in the patients with the Ki-67 over 30% was about 25%, so which is a very high risk of CNS relapse versus less than 10%, probably closer to 5% in those who were less than 30%. We can move on. TP53 mutations have been studied independently, and we can see a big difference in survival based on TP53 mutation. This study that was published in Blood a few years ago showed a median overall survival in patients without a TP53 mutation of over 12 years, which is very good, versus a median survival of less than 2 years in patients who had this mutation. So you can see these are very important prognostic factors. What I will say is that there are many studies ongoing, but we don't, and we'll get into this a little bit later, but we don't necessarily know how this impacts treatment approaches just yet, but we do know how it affects prognosis. And the MIPI score, basically we have these scores for most types of lymphoma, different cancers, and we take in factors, sometimes patient factors, sometimes disease factors, and the study will find a certain combination, and if it's significant, then we can use them, and if it's validated, then we can use this as another way of evaluating how is this patient going to do at baseline. And this is different than some of the other features I showed you, because those are all dependent on the tumor biology. This also takes into account the patient, such as how old is the patient. If someone is 90 years old, it's going to be harder to treat them. They're probably going to have other comorbidities, and they're probably not going to do as well as someone who's 40 years old, who you could treat aggressively, who may not have other comorbidities. ECOG is a performance status, meaning independent of age, how functional is that patient? Can they get up, spend most of their time out of bed? Do they exercise all the time? That kind of thing. And then LDH is a blood marker. White blood cell count is another blood marker. And then the Ki-67 is a biologic component that has to do with the tumor itself. And you can see this chart on the left breaks people up into low, intermediate, and high risk, and you can see how those curves spread out, and you can see that patients who are low risk are going to do much better. And now we can go to the next slide. This was a recent review just published a couple months ago in JCO, which actually broke up a subgroup. I like the way this chart broke up, kind of a subgroup of high risk that they call ultra high risk mantle cell, which includes de novo blastoid. So that would mean a patient who came in with blastoid variant disease rather than someone who started off as a common type and then changed into a blastoid. Just kind of a little nuance there. Someone with a Ki-67 over 30%, TP53 mutated. I think some of these other gene mutations we don't know quite as much about just yet, but there are some others that are considered to be higher risk. And then obviously if they come in with CNS or AKA brain involvement, then that's going to be much higher risk. We can move on. So what kind of workup do we do? So if I were to see you in the hospital or in my clinic, I would want to start with some labs, CBC, which is a complete blood count, electrolytes, the CMP will evaluate your liver tests, your kidneys. LDH, like I mentioned earlier, is a blood marker of lymphoma cell turnover. So the more aggressive, the more bulky the disease, the higher the LDH generally. Tumor lysis labs. Sometimes when you have an aggressive lymphoma, as the cells grow and die and grow and die, the contents of the cells are released into the bloodstream and need to be filtered out by the kidneys. So sometimes that can damage the kidney. So we check markers in the blood for that. We need to check hepatitis B whenever we're going to give a drug called rituximab, which just about everybody with mantle cell will get. If they've been exposed to hepatitis B in the past, we need, which is very well tolerated because they can have basically a hepatitis or inflammation of their liver if they're given the rituximab and they've been exposed to hepatitis B in the past. It's a fulminant hepatitis. Everyone gets tested for HIV, and then you can test peripheral flow cytometry, which looks in the blood for mantle cell. You would really only do that if your white blood cell was elevated. Not every patient with mantle cell would need that. That's why I put plus or minus, and then plus or minus a bone marrow biopsy. If their blood cells are low, or if they seem to have lymphoma circulating in their blood, then you'd want to do a bone marrow biopsy. Our standard imaging is a PET scan. That's what I showed you earlier, which has that functional component that lights up, that makes it a little different than a CAT scan. It gives the images that show the structure like a CAT scan, but also has a functional component that shows glucose uptake, basically how active are these cells, and that's very helpful in lymphoma. If the cells are very active, it's more likely to be lymphoma. If a patient's going to go to stem cell transplant, we want to get an echocardiogram. Mantle cell can often have GI or gastrointestinal involvement. Sometimes you don't even know that they have it. So if you do think that you have a limited stage, meaning stage 1 or 2, we do recommend doing endoscopy and colonoscopy, so upper and lower, and taking random biopsies to make sure that it isn't really a higher stage mantle cell. And then for high risk, like we mentioned earlier, the blastoid or the high Ki67 patients, I would do a CNS workup with a lumbar puncture or an MRI brain looking for any brain lesions if they're symptomatic. So how do we stage lymphoma? So I often say that lymphoma staging is the easiest of all cancers, and that's because it's the same for all types of lymphoma. And we have so many different types of lymphoma, but we stage them all the same, and it's pretty straightforward. The way I like to describe it is if you have one lymph node or one site, then that's stage 1. If you have 2 or more on the same side of the diaphragm, so either in your thorax or in your abdomen, that's stage 2. If you have lymph nodes above or and below the diaphragm, that's stage 3. And if you have any visceral organ involvement, so anything other than just lymph nodes or spleen, then that's when it becomes stage 4. Response criteria. So I don't think I need to get too technical here, but just the important takeaway is that everybody who comes in will get a staging PET scan, and then we will treat the patient for a certain number of cycles with whatever treatment they're getting, and then they'll get another PET scan. And what we want to see on that is that the tumor is shrinking and that it's not lighting up as much. If it's not lighting up as much, then they are responding. If they're lighting up less than the liver lights up naturally, then we call that a complete response. If it has shrunk, but it's still lighting up a little bit more than the liver, but less than in the beginning, then we call that a partial response. Obviously, if it's growing, it's progressive disease. So here's a question that we had. So this patient had lymph nodes above and below the diaphragm. So based on what we discussed earlier, what stage is the patient's mantle cell lymphoma?
And for those of you using the text, if you think it's stage 1, go ahead and put in A, stage 2B, stage 3C, or stage 4D. And let's take about 15 more seconds. Again, these are anonymous. All right, Dr. Dittus, we seem to be trending pretty heavily on stage 3. How are they doing?
Yeah, great. I'm actually impressed. Everybody just staged lymphoma. The patient had nodes above and below. Does not seem to have any organ involvement based on the PET scan. So the patient would not be considered a stage 4, and stage 1 and 2 would only be on one side of the diaphragm. So this patient is a stage 3. So now we have all of our background information. We've diagnosed our patient. How do we proceed with treatment? So mantle cell lymphoma treatment is not straightforward, and the reason for that is you have a lot of variability in terms of how aggressive you can treat these patients. In general, we do still approach mantle cell as an aggressive lymphoma that requires aggressive frontline treatment to induce the deepest and longest remission that we can get. With that in mind, if there is a clinical trial open, we always want that, particularly in rare diseases such as mantle cell, but really for anybody as an academic center, that's always our first go-to. Now, standard of care, meaning treatment in the absence of a clinical trial, we have to look at the patient. We look at the patient and we take into account their age and what we call their performance status, which is what their functional ability is. So someone who's incredibly fit and young is going to be treated very aggressively with the hopes that that is going to lead to a longer remission for this patient. Remember, we're not trying to cure these patients, unlike most other types of really all other types of aggressive lymphoma. We're trying to induce as deep a remission as possible at this point. So our algorithm which is here at UNC, which is similar to many other algorithms, but again, different institutions do have their own takes on things, is that if a patient is fit and less than the age of 75, we can consider an intensive approach. Now, obviously, less than 75 leaves a huge range of patients. They could be 45 and marathon runners, or they could be 72 and have many comorbidities. So you can't just take the age into account. You also need to take their performance status and comorbid conditions into account. So if you do say that this patient is eligible for an intensive approach, our standard is to use a regimen called R-DHAX, which is a variant of R-DHAP, which you may have heard of, which is a classic salvage regimen that we use for diffuse large B-cell and many other types of lymphoma. We use it frontline because it has a drug called high-dose Cytarabine, which I'll show you some data on soon enough. And that seems to at least with some data, improve responses and at least progression-free survival. So we use R-DHAX. We generally give about 4 cycles, and then we take them to transplant, to an autologous stem cell transplant. There was a big trial recently that looked at maintenance rituximab after transplant. The patients either got placebo or got maintenance rituximab, and those getting rituximab had an overall survival benefit. So we'll show you that. So maintenance rituximab every 2 months for 3 years is also a very important part of the treatment. There are many other single-arm studies that have looked at other regimens such as hyper-CVAD, the Nordic regimen to transplant, hyper-CVAD with or without a transplant, and all of these regimens, none of them are wrong. We find our R-DHAX to be very well tolerated, and the data are very good, especially the most recent randomized trial, which used DHAP and or DHAX as the induction regimen. So we feel that this is a well-tolerated and very effective approach. So that's what we do here at UNC. Now, none of these have been randomized against each other, so I can't tell you for sure that our R-DHAX is better than the Nordic or hyper-CVAD, but I can tell you based on recent data that it is a very effective approach. Now, what if your patient is over 75 or are just really, not as fit functionally, or have many medical problems, or just don't even want aggressive treatment? Well, we have less intensive chemo. BR is standard. BR is bendamustine rituximab, and I'll show you some data on that. There is kind of a slightly more intensive regimen called R-BAC 500, which is basically BR, bendamustine rituximab, plus lower dose cytarabine than you would see in the above regimens. Still is a step up from bendamustine rituximab in terms of aggressiveness. It's something that can be considered. VR-CAP is the regimen that includes Velcade, which is a newer targeted drug, well, newer relative to traditional chemotherapy drugs, but not exactly new. And then we have oral approaches, which are lenalidomide, which is Revlimid, plus rituximab, which works very well in mantle cell lymphoma. And we have a ibrutinib or a acalabrutinib. Usually these oral therapies are reserved for the relapse setting, but in certain patients, you can consider it frontline. Next slide. So we have our 83-year-old patient, and do we feel that this is someone who would want to offer an intensive approach to therapy?
All right, and just a few more seconds, if you would. Dr. Dittus, we're falling on B for the majority of the participants. How did they do?
Right. Yeah, you did great. So, again, we like to say age is just a number, but sometimes the number is important. so over 75, we're not going to, over 80, we're not going to transplant you. And really, she would do very poorly with an intensive induction regimen. So we would offer her less intensive therapy. We could go to the next slide. So what is the role of high-dose cytarabine? I mentioned this earlier. So this is the intensive approaches for universally will incorporate some degree of high-dose cytarabine, and that's generally thought by providers to be an important part of the treatment for mantle cell. This was a phase 3 trial of about 500 patients. Everyone was less than 65. And the patients either got 6 cycles of R-CHOP and then were consolidated with an autologous stem cell transplant, or they received R-CHOP as well as 3 cycles of R-DHAX, which included the high-dose cytarabine, and then went to auto transplant. We can go to the next slide. I just boxed around some of these. These are the high-risk patients. So blastoid mantle cell, about 9–10%. Ki67 over 30%, a quarter to almost a third of patients had that. So this was not a totally low-risk group. And then about a quarter were high risk by the MIPI score. We can go on. So this is looking at the time to, so the probability of no treatment failure, or the time to treatment failure in the control group, which was the R-CHOP only, so no high-dose cytarabine, was about 3.9 years versus 9.1 years in the cytarabine group. And you can see these curves are statistically significant. The 5-year time to treatment failure was 40% in the control versus 65%. You can see the overall survival was 69%. This is the bottom chart now. In the control group, and 76% in the cytarabine group. This was not significant. So the overall survival, while it looks like it's trending that way, it was not significant. But there is what we call a probability of no treatment failure, which is kind of similar to a progression-free survival. It's a different statistical way of looking at it, so there does seem to be some benefit to cytarabine in terms of when, delaying the time to requiring another treatment. What about this R-DHAX regimen that we like to use here? Well, we base our approach on this New England Journal study that was published 3 years ago. The study wasn't studying whether R-DHAX or DHAX. Remember, R-DHAX and R-DHAX are basically the same thing. They just use a different platinum-based drug. DHAP uses cisplatin and DHAX uses oxaliplatin. Oxaliplatin has much less renal toxicity, so that's why we like to use it. And we feel like patients tolerate it much better. Either way, in the study, they allowed either regimen. So a significant proportion got DHAX. They received, everybody got 4 cycles and then went to autologous stem cell transplant. So the randomization was not for the induction regimen. Everyone got the same thing. So it wasn't studying whether this was an effective regimen or not. What it was studying was whether maintenance rituximab improved survival after the transplant. So half the patients were observed and half the patients were randomized to get maintenance rituximab every 2 months for 3 years. And we could go to the next slide. And we could see our high-risk patients. So again, about a third of the patients, even in both groups, observation and maintenance rituximab had a high Ki67. High-risk patients, intermediate and high risk, made up, over a third of patients, closer to half of patients. And then blastoid and pleomorphic taken together made up probably about 10 to 13 or 14%. And what we see here are the charts looking at progression-free survival, so the amount of time until patients either progressed or died, and then the overall survival benefit, which is just looking at death from any cause. And which is really the gold standard, what you want to see when you change your practice based on a study. And what we saw was a significant difference in both PFS as well as overall survival. So the 4-year progression-free survival for patients getting maintenance rituximab was 83% versus 64%. That's the top curve over here, the rituximab group. And then the 4-year overall survival was 89% versus 80% and that was statistically significant in terms of overall survival benefit. So that's why if you were induced, got a transplant, you will get maintenance rituximab after that. That's become standard after this study. So what if we want to take a less intensive approach, like for our patient? Well, there was a study published 7 years ago now, which was really a seminal study showing that bendamustine rituximab versus the old standard, which is still standard for many other types of lymphoma, but R-CHOP, which we use all the time for aggressive lymphomas, that it randomized patients to get bendamustine rituximab versus R-CHOP in indolent types of lymphoma, as well as mantle cell. And patients either got 6 cycles of BR, which is bendamustine rituximab, or R-CHOP. Go to the next slide. The mantle cell did not make up the majority of patients. The majority were follicular lymphoma. Mantle cell made up about 20% of patients, so it was the second biggest group. And these were the overall results. Now, remember, we're dealing with indolent lymphomas, slow-growing lymphomas. Patients often live many, 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 many years with these lymphomas. So usually you're not going to see an overall survival benefit. So what we are usually looking for in this is a progression-free survival benefit, meaning when do they progress? Do they progress later with this treatment than they would with the standard treatment? So the standard treatment being R-CHOP, you could see the bottom curve, the top curve is bendamustine rituximab, and there is a significant difference between the two. And this is all comers. This is not just mantle cell. This is follicular, mantle cell, marginal zone, all different types of indolent lymphoma. But it showed that the median PFS was about 70 months versus 30 months. Okay? And then if we go to the next slide, they did show the break up the results based on the type of lymphoma. And the vast majority of cases were follicular, which is the most common type of indolent lymphoma. And you could see a statistically significant difference there in bendamustine rituximab versus R-CHOP. And then over here on the right, MCL is mantle cell lymphoma. And we could see that bendamustine rituximab had a significant improvement in progression-free survival, 35, so about 3 years for bendamustine rituximab versus about 2 years for R-CHOP. Another less intensive approach is a regimen called VR-CAP, which is really a variation on R-CHOP. What you do is you take out the vincristine and add Velcade. Velcade is a more targeted drug with a novel mechanism compared to traditional chemotherapy like vincristine. The reason you don't include it is because they both can cause peripheral neuropathy, so nerve pain and damage. And if you were to give them both together, you would have a significant amount of neuropathy. So we take out the vincristine and add in the V is Velcade, also known as bortezomib, which is very often used in multiple myeloma. This was a phase 3 trial randomizing these two regimens against each other. If you go to the next slide. And just moving through, on the left, we have progression-free survival. On the right, we have overall survival. And we can see that there was a progression-free survival benefit, and the patients, the progression-free survival in R-CHOP was actually quite low at 14 months. One could argue that's lower than we would normally see, and I'm not sure the exact reason for that. And the VR-CAP was about 2 years. The overall survival was not statistically significant in the two groups. So what we see here is a PFS or progression-free survival benefit for VR-CAP. And the reason I share these two studies is that, we really have shown that two different regimens now perform better than R-CHOP for mantle cell lymphoma. So really R-CHOP is kind of at the bottom of the list for at least in the frontline setting for our mantle cell patients. And then what if we don't want to give chemotherapy at all? Well, we do have chemotherapy-free options, and a pill called Revlimid, which is the trade name, also known as lenalidomide, which is a derivative of thalidomide, which some of you may remember from several decades ago when it caused birth defects in patients, pregnant women who took it for nausea. Obviously it was taken off the market and then repurposed ultimately for different types of cancer treatment with a black box warning that you cannot be sexually active or get pregnant while on it. And lenalidomide is a derivative of that drug. It was studied in a phase 2 trial looking at 38 patients, median age 65, and it was given with rituximab. It was given weekly. The rituximab was given weekly and then every other month. And the Revlimid or lenalidomide and the standard way to give it is at 3 out of 4 weeks. So you have 21 days where you take the pill once a day, and then you have a week off, and then 21 on, 1 week off. And the results of this study we can see in the next slide. showed an overall response rate of 92%, which is excellent, and a complete response rate of 64%. And that was median follow-up of 30 months. So the responses are excellent to Revlimid. Even, whether it's there are other data looking at the relapse setting. So Revlimid is very active in mantle cell lymphoma. It's an option for patients who you think can't tolerate chemotherapy. The 2-year progression-free survival was 85%, and the 2-year overall survival was 97%. So again, it has excellent efficacy in this in this group. So after talking a little bit about some different treatment approaches, intensive and less intensive, would you treat our patient with R-DHAX, R-CHOP, rituximab alone, or bendamustine rituximab? So it was a little trickier.
All right, just a few more seconds if you haven't already submitted your answer, and thank you to everyone for participating in this. Dr. Dittus, how are they doing?
Yeah, so she's 83, but is fits. So I would not consider R-DHAX. I'm glad no one picked R-CHOP, because even if you're taking a less intensive approach, I would not. I would choose something other than R-CHOP, because we showed that other regimens work better. She's fit for bendamustine rituximab. That's what we would go with in her. And we'll talk about how to give it in a patient who's 83. Rituximab alone is always an option, but I think that we can add a little something to rituximab alone. That rituximab alone, you can always give if you really can't give anything else, but I wouldn't expect the remission to last very long with that. Okay, next. So going back to our case, she was started on bendamustine rituximab. We do a 20% dose reduction in a patient, usually in their 80s. She completed 6 cycles without, she did very well through therapy. And this is just a chart looking at her LDH, which came down nicely with treatment. Next slide. This was her PET scan. On the left is the one that I showed you earlier, and on the right was after treatment. So you could see all in her armpits, her arms are up like this, and you could see in her axilla, we don't see anything lighting up. We see all of that black in her belly is all less now. What you see residual is her brain at the top, 2 kidneys, and then you see her bladder down at the bottom, and probably some bowel uptake over there on the left side, and that's all physiologic. So she was in a complete remission. And she remained in complete remission for 3 years. Unfortunately, a few months ago, she came back. She's now 86. She developed severe night sweats, it's called a B symptom, fevers and weight loss. Her PET scan showed diffuse lymphadenopathy, and she was diagnosed with relapsed mantle cell. So what's our approach to relapsed mantle cell lymphoma? So obviously, if there's a clinical trial, that would be our approach. If the patient is young and still fit for aggressive therapy, we can use any salvage therapy that we would normally use for relapsed lymphoma, such as ICE or any of the other chemo regimens that we talked about. They hadn't had a transplant in the frontline setting. You would consider that if you got them into remission. If they've had an auto transplant in the past, you can consider an allo transplant, which you would need a donor for. And now, very interestingly, which I do want to have time to get to, is that we have a commercially available CAR-T product that targets CD19, specifically for mantle cell, called Tecartus. If we want to be less intensive in the relapse setting, we can do a BTK inhibitor, such as ibrutinib or acalabrutinib, and now zanubrutinib, or we can do Revlimid, which I showed the frontline data for, or a pill called venetoclax, which also has efficacy in mantle cell. Go to the next slide. I did want to talk about CAR-T, because this is some of the newest data that are coming out in relapsed lymphoma, which is relapsed mantle cell, which was just published this year and was just approved by the FDA and commercially available in the last few months. This is based on a study looking at a phase 2 study in 74 patients, 68 of which received CAR-T. All the patients had received a prior BTK inhibitor, and they got fludarabine, Cytoxan, lymphodepletion. Go to the next slide. Baseline characteristics, the median age was 65, but importantly up to 79. intermediate or high-risk MIPI was about half the patients, and Blastoid was about a third. So these were, again, high-risk patients. All the patients received a BTK inhibitor prior. And we could see that the response rates were excellent. The complete response rate was about 40%, and the partial response rate the complete response rate was 67%, and the overall response rate 93%. So patients had some type of response, just about everybody. And the question is, how durable is that response? And it does seem like of the patients who responded, they did quite well. The 1-year progression-free survival was 61%, and the 1-year overall survival was about 83%, taking into account these are heavily pretreated patients. We can go to the next slide. The important thing, and for those of you who don't know about CAR T therapy, this is a modality where we apheresis out patient cells, T cells, in the lab, manufacture them to target the lymphoma, and then put them back, apheresis them, or infuse them back into the patient, and then it targets the lymphoma or the cancer. And what we worry about is basically an overwhelming immune response, which you can see in this, which any adverse event, there was about 79% of patients. Cytopenias we saw, that's primarily from the chemo, the lymphodepletion they get in the beginning, which is 69%. We can go to the next slide. And then CRS symptoms such as fever or neurotoxicity, which is separate from CRS, those occurred in about a third of patients had a neurologic event, and fever about grade 3 or more, about 10%. Move on. So our patient is now 86 years old. She's had chemotherapy, has relapsed, and she's symptomatic. What treatment would you start now? Well, none. Would we just initiate surveillance? What about salvage chemo and consolidate with an auto transplant? BTK inhibitor, which is a pill, or CAR T therapy, which that study went up to age 79.
All right, and so thank you. A few more seconds to submit your answers, and then the next time Poll Everywhere pops up, it will be with an opportunity for you to ask questions. So please be thinking about those. Dr. Dittus, how did they do?
So we have the biggest difference in this one of all the questions, it looks like, but the BTK inhibitor is the route that I would take in this patient. The reason I wouldn't initiate surveillance is because she's quite symptomatic and feels terrible. So I wouldn't want to just watch her. We'd want to do something to make her feel better. Again, we wouldn't treat her aggressively. If we wouldn't do an auto back 3 years ago, we wouldn't do it now. And then CAR T therapy could be considered for a very fit 80 some odd year old, but I would probably go with a less intensive approach in a patient like this. So BTK inhibition is a very important, is increasingly important role in mantle cell lymphoma. Ibrutinib was the first one that was studied in mantle cell with complete response rates of about 21%, overall response rates of 68%. Ibrutinib has also been studied with another oral agent called palbociclib, which increases the response rates. Acalabrutinib is a newer drug that's seems to be more targeted and has improved response rates. And then zanubrutinib is again even higher response rates. All of these are approved for mantle cell in the relapse setting. Zanubrutinib just getting approved, but also a very new drug. So for this patient, I decided to go with a BTK inhibitor, and she was started on acalabrutinib, which is seems to have fewer side effects than ibrutinib, and seems to be a little more potent. And she, within a month, her symptoms totally resolved, and we're actually awaiting her restaging PET scan, which she's having right now, after 2 months of therapy, and we'll see how she's responding. Just a quick overview of the trials before we finish up the talk. We do have a lot of clinical trials here at UNC to keep in mind. One study that we've accrued a lot to is a randomized phase 3 trial looking at patients who are MRD negative, so doing a test to see if they have any residual mantle cell lymphoma after induction, whether or not they need to receive a transplant, a stem cell transplant. So that's a really important frontline study that'll ask us that'll tell us the importance of transplant in MRD negative patients. We just opened up a 3-arm phase 2 study for patients less than 70 for the frontline setting, looking at bendamustine rituximab high-dose cytarabine versus bendamustine rituximab high-dose cytarabine and acalabrutinib, and then versus benda rituximab and acalabrutinib. So asking whether a BTK inhibitor helps intensive therapy and whether you need high-dose cytarabine. So looking at that question again. In the relapse setting, we have a study looking at ibrutinib with palbociclib. We participated in the early pilot study looking at that combination, and now we have another broader phase 2 study looking at that combination. The Loxo trial is a study that includes many types of B-cell lymphomas and CLL in the relapse setting, which is the newest, a much newer BTK inhibitor similar to ibrutinib. And then we also have a CAR T trial for any CD19 positive lymphomas. And next slide. References, and that's it. Thank you, everyone, for coming. Sorry I went over a little bit there.
Oh, that's okay. And we do have time for questions. While we're waiting for people to submit any questions they may have, let me ask, what are behaviors, if any, that patients may be able to utilize to extend the length of their remissions? Obviously, that's got to be a very anxious time. And are there things that you find that patients can do to extend that?
Yeah, unfortunately with mantle cell, I like to reassure patients and tell them that there's not a whole lot on their end that they can do to keep the cancer away. If the cancer is going to come back, it's going to come back. If it's not, it's not. And I try to reassure them that they shouldn't stress too much on what they do being a cause of what happens with their cancer course. Usually what I stress is just a healthy lifestyle, good diet, exercise. The reason for that primarily is that when it does eventually come back, the better shape you're in, the more fit you are, that just means that we can treat you easier, and that will help how well you do long term.
Great, thank you so much. We do have a question came in. What are the most common side effects of BKTI?
Yeah, so the BTK inhibitors, so ibrutinib was the first one that was approved for mantle cell. And the things that really popped out at us for this were two things. One, an increased rate of atrial fibrillation, which is a cardiac arrhythmia, and then an increased bleeding rate. And those are things that actually became, a little concerning. I mean, they are rare, but not so rare that you never see it. Around 10% or so patients would get those. So they're things that we definitely need to watch out for. Now, the newer BTK inhibitors seem to have less of that. Now that's not based off of a randomized trial where we compare them directly. That's looking at separate single-arm trials and just seeing what the results are. And there could be different factors at play, but it does seem like the newer ones are there's less off-target effects, so it's more just targeting the lymphoma itself, and we seem to think that we see less of the cardiac arrhythmias and bleeding events.
All right, thank you so much. And it looks like that was, we did have a comment. Great presentation, nice review. Thank you, Dr. Dittus. Let's go ahead and do a few other thank yous and wrap up. We want to thank North Carolina citizens, the taxpayers, for their generous support of the University Cancer Research Fund through the North Carolina General Assembly. We want to thank the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, John Powell, and Anita Woodyard for all the work they do on this and every one of our lectures.